We are good in the program and in time, so the next speaker has a lot of time to come to the stage. Professor Grainne O'Kane from the St. Vincent University Hospital in Dublin, Ireland. She's a medical oncologist. We know her from her previous time in Toronto, I think. But please go ahead and show us everything, the inequalities on cholangiocarcinoma patients in Ireland.
Thank you very much. It's really interesting to follow these two amazing talks that really speak to how we need to be more global, how we need to reach every patient and learn from every patient across the globe so no one's left behind. I am never giving this talk at a meeting. So I'm usually giving, oh my God, this is going ahead on its own. I'm usually giving talks on molecular profiling for cholangiocarcinoma or clinical trials. And so this has been a very different ask for me, and I very much thank Helen for the invitation to speak today, because I really firmly believe that I can't do my research unless the basics are right for the patient. I was really struck by Andrea and John's conversation earlier about pathways for patients and the call to action for physicians, the need for increased awareness and education. But for me, there's also a call to action for every physician to call out bad practice and to call out disparities and to really try and work with governments and patient advocacy groups, really to begin to iron out these disparities. And this is what I became quite passionate about. It's not my research focus, but when I came back to Ireland from living in Toronto for 7 years, I'm going to explain to you what I saw in terms of the disparities that we know exist. So, first of all, I'm going to tell you about the positives. So Ireland is not the leprechaun country that is just right beside the UK. We're a very much developed country with excellent cancer care. And this infographic is something that you probably see from many countries. Now, these bother me because what happens is here you can see that we all need to know our incidence rates. We all need to know our prevalence of cancers. And the positives are really important. So government will use this to say we are doing extremely well in our cancer care. We're increasing our survivors by 50%. And we talk about our most prevalent cancers, and that's amazing. But we do not go into that personalized approach of rare tumor types like patients with cholangiocarcinoma. And I can take this and I can say to government, okay, can you explain to me why we have some of the highest mortality rates in Europe for cholangiocarcinoma patients? And that's never shown in this type of infographic. Now, we are lucky, going back to the difficult questions of surgical care early and whether that needs to be centralized. We do have 7 cancer centers across Ireland, and I'm not counting Northern Ireland. And I should mention, I'm actually from Northern Ireland, but living in the Republic of Ireland. We have 7 cancer centers where we coordinate our care. We have 2 surgical centers. So we have a national cancer control program that has ensured that surgery, including rare tumor types, are centralized. So HPB is centralized in 2 specific centers in Dublin and in Cork. And that's been a real plus for us, for patients. But you will see that there are a number of other hospitals. And this is because there are a number of private centers that deliver care in Ireland also. Not for surgery, but for medical oncology. And we can argue the pros and cons of that. But for me, for cholangiocarcinoma patients, I really believe that they need to be seen by specialists, given the very much moving field. But this is not always what happens. And so patients end up coming to us, emailing for second opinions because they've been given wrong information in potentially private hospitals. We talked a little bit earlier about data, and we saw the incidence of intrahepatic cholangiocarcinoma potentially going up because of coding. I was quite struck when I came back a couple of years ago to see that our incidence rates were about 200 cases per year of biliary tract cancers, and I thought this is definitely not right. So when we went back and looked at our codes according to ICD-10, we saw that this doubled. And this is really important information for us as we begin to think of our pathways. If you haven't read the Lancet Regional Health papers, I don't know if Chiara's in the audience, but Chiara and Lorenza, as part of the ENSCA Cost Initiative, have really done amazing work in terms of mapping cholangiocarcinoma across Europe. And if you see here, and if we look at Ireland, we can see that we have all potential components of the pathway, but it's still not working. So we heard from patients today about being in primary care and not getting in. I will give you an example of a patient and why I think coming from North America to Europe while I might be provocative and think that we need to really flip how we organize our MDTs and how our patient care pathways do not always serve the patient. So I've started co-triaging patients for HPB with my surgeons. A patient was referred with a cancer of unknown primary, as often our cholangiocarcinomas were. She was not in my catchment area, so technically I could have said, refer that patient to X hospital. That would have been another few days, another week potentially for the patient to be seen by medical oncologists. And I actually got the nurses to ring that patient and say, see, does she want to come in to see me? She came in the next day. Her calcium was 3, her ECOG performance status was 4, and she was 48 years of age. She had a large dominant intrahepatic cholangiocarcinoma. Looking at the imaging, she had an OGD and colonoscopy that were negative. And her MDT has still not happened yet. So I think we do need to, in Europe, I'm not sure if this is the same for everybody, but certainly in the UK and Ireland, a lot of patients often wait to MDTs before being discussed. A lot of oncologists will not see patients without histological diagnosis. I personally do not favor that approach. So this is the hospital that I work on. I work in the university hospital. I have a public-only contract. On campus, there is a private hospital, and we are affiliated with a university, which is very close by. We offer almost all aspects that you need for cholangiocarcinoma care. We have liver transplantation. We spoke about this earlier. We actually transplant up to 3 centimeters. We have the Mayo protocol in place. We have liver resections. We have Y90, radiotherapy, systemic therapy. And I'm going to speak a little bit about clinical trials. And we have very good quality care in terms of nursing and palliative care support. How we deliver care in Ireland is delivered by our National Cancer Strategy and our National Cancer Control Programme. And these are important, and I think this is important for the UK also, because there has been a number of publications looking at national cancer strategies and how they can really help with survival data if you have an informed strategy that is delivered by government. But within our strategy up till 2026, so this has to be rewritten, there was only one KPI out of many on clinical trials, and that was aiming for a 6% access to therapeutic trials for all patients across the country. And that is, for me, not enough, and we are not even close to that number in Ireland at the present time. We do, however, have specialists in every discipline. We have the people. And for me, the people are the most important aspect of being able to deliver a successful program in any tumor type. So we have the people. So what is wrong for me in terms of disparities? Well, when I came back from Ireland, there was 2 cases that led me to speak in government because I became so upset and cross about them. The first guy here is actually a hepatocellular carcinoma patient, but he was in hospital. I had just started the new job, and a hepatologist rang me and said, look, Grainne, this guy has a very extensive hepatocellular carcinoma. There's tumor thrombus, his bilirubin's 300. Look, could you just come by and see him? I don't think there's anything you're going to be able to do. And I went to see the patient. He was a new diagnosis of hep C. He was told he had 6 weeks to live. And through multidisciplinary approach, we got him, he had bile duct invasion as well. We got his bilirubin down. And I had no access to atezolizumab and bevacizumab at that point once he was decompressed. Now, I mentioned to you that I live in the Republic of Ireland, but I'm from the north of Ireland. I hold a British passport, I hold an Irish passport, I hold a Canadian passport. So if I had been in the north of Ireland, this was June 2022, this patient would have had access already to those drugs in December 2020. So I had to beg for these drugs through a compassionate access program. I was able to get the drugs for the patient. The patient is still alive on treatment, was able to get married, fulfill all those things, all those goals the patients need to do, reminding us of what we're actually here to deliver. This patient on the right was like a month later. I was having a really bad time at this point in the hospital. She had been monitored for a liver lesion that was being called benign. And this is a really awful story because thereafter, the liver lesion was growing, and then she was being worked up for a cancer of unknown primary. So you can imagine the time frame to this. At the point she came to me, she had multiple liver-confined disease, but multilobar, did have a dominant intrahepatic cholangiocarcinoma, biopsy proven. And at that time, cisgem durva was available for patients, but not in Ireland. Now, she was well known to the public healthcare system. She had private health insurance, so I was able to access molecular diagnostics for her. I couldn't in the public healthcare system I was working in at that point in time. We can today. And I couldn't access immunotherapy for her, but I could in a private hospital. So I had to send her to a colleague in a private healthcare system to access molecular profiling and to access standard of care immunotherapy. And this is still the case in Ireland today for durvalumab as part of the TOPAZ study. And you know, I can't refute the fact that 50% of patients in Ireland have private health insurance. All those patients now have access to EMA-approved drugs quicker than NICE in private hospitals, but not in the public healthcare system. I'm going to go into that in a little second. There's actually been a number of news articles on this because we're now not just in a two-tier system, but even within our private health insurances, there are disparities depending on what plan you have and what access you might have. So we now have like a three-tier healthcare system in Ireland in terms of access to drugs. And so with these two patients, if they had been in the north of Ireland, they could have accessed drugs, or private health insurance, they could access drugs. We've spoken to government about this, along with our national charity, the Irish Cancer Society. We spoke in the Oireachtas a couple of years ago. It's amazing to have Irish patients here today to hear their voice. And we've tried to represent their voice to really highlight the disparities that are existing. And I'm going to explain to you why this is important. It's not just about accessing drugs. And in Ireland, there was actually a huge news article piece yesterday on this. We are very slow to reimburse drugs compared to the rest of Europe. You can see here, the averages are here, and this is where Ireland is. And we've actually, you know, when I see this, and you know, government don't listen, politicians don't listen, the only way to drive this is data. So when we looked at, with a specialist registrar, approvals across 6 years, and looked at NICE reimbursement and looked at Ireland and our reimbursements, you can see that in a 6-year period, 82% of EMA-approved drugs were reimbursed by NICE, 50% in Ireland. But I'm just going to take you to the timelines. If you look here, in that time frame of reimbursement, you have 11.1 months. This is from EMA approval to access and by NICE, and then 25 months in Ireland. And in GI cancers in particular, this was very notable, really over doubling the time. And in GI cancers, where patients often can't wait for these drugs. So this is a big problem for us in Ireland. Again, highlighting the ENSCA cost initiative and looking at the access across Europe. This isn't just inherent to Ireland. And I'm here speaking as a medical oncologist for Irish patients, but we need to speak for every patient across Europe and the UK so that every patient has access. Because that's when we can do our research. That's when we can really explain and look at the preventative mechanisms, when we can reach every patient. So we know all the drugs that are improved: durvalumab, pembrolizumab, pemigatinib, futibatinib, ivosidenib. Ireland, at this point in time today, public patients can't access these. Pemigatinib is nearly there. Ivosidenib will come, I hope, durvalumab, given that we're making a lot of fuss about it. But these have all been declined at this point in time. Now, why I think this is important is not just the knock-on effect of patients getting access, getting fair treatment, parity to access, but this is also important in terms of clinical trials. And we've heard about the wonderful work from John Bridgewater and others in terms of accessing ABC10. Other trials, if we can't access the standard of care in the first-line setting or FGFR2 fusions in the second-line setting, then we can't access the second-line drugs on clinical trial if they haven't been able to access the first. But disparities in trial access in Europe is a big problem. And here you can see, so the blue is people who have less than 200 trials, less than 500 trials, less than 1,000. This was presented at ESMO a few years ago. And this is a call to action, not just for oncologists who try to get trials, believe you me, but we also have to have conversations with our pharmaceutical partners to really understand that as a continent and the UK, we really want to bring trials to Europe. And I honestly think political situation at the moment means we probably have opportunities to do that, but we do need to work together in order to serve all patients, because I spend a lot of my time, having come from Toronto work at Access Trials, sending patients abroad to trials, and that's often to the States where they spend a lot of money potentially trying to access a clinical trial. Now, that's not to say we can't deliver in clinical trials. So this same article actually showed that Ireland, okay, you're not going to be able to see this, but you have to take my word for it. Ireland, during 2010 to 2018, actually had the biggest growth in terms of the number of clinical trials. We've just put over 11 patients on the Provide IDH1 trial, so in a molecularly driven trial, rare tumor type, but we were able to deliver on that particular trial. So that's something that I think we need to address as a community in terms of patients being able to access clinical trials, accessing drugs. And really, a lot of this work And the reason why I'm here today is because of the patients. And this conference is amazing, and I know it's the same with the Cholangiocarcinoma Foundation annual meeting that I missed in the US. In having the patient voice at the center, I have now learned that I can't change things, but patients can. So this group, the Cholangiocarcinoma Foundation Ireland, I'm extraordinarily proud of these patients that came together to form this group. Helen and the AMMF and the Cholangiocarcinoma Foundation have been hugely supportive. I want to especially mention Helen and Paul and John, who have been writing letters for us, putting together patient voices, clinician voices, to write to government to say this is not good enough, because we do need support globally. We are a small country. This is a number of other different charities. And I could tell you lots of stories that we've heard today, very similar stories that are so powerful. And I'm really grateful for the patients that are sharing their stories here today, because honestly, I don't think you realize the change that you are probably making. So really, I am here to highlight, as a clinician who is very much engaged in research and clinical trials, that we have a huge problem with disparities in terms of the pathways from the beginning of time, I call it time zero, from presentation to the GP, right through to accessing drugs. We need to work together. I love hearing the stories about the pump happening in these countries, but I want this to happen in every country, and I think we do have the opportunity to do that. The irony of our 1916 proclamation in Ireland, when we separated from England and the UK, was that we promised religious and civil liberty, equal rights and equal opportunity to all its citizens. And now we're seeing in Ireland a system that's two-tier, where I'm referring my public patients to the private, and many of my public patients are not getting parity in terms of their treatment. That's it from me. Thank you very much.